Hi, this is Dr. Krishna Deepak, and welcome to another episode of Stethoscope Sip, short for Stethoscope and Sip. This is a unique podcast where a doctor interviews another doctor and for the benefit of other doctors. So, today we have a great intensivist, a clinician par excellence, that is Dr. Basavaraj Kuntoji. So, let us welcome Dr. Basavaraj Kuntoji, who has lots of experience in the field of critical care medicine. Sir, welcome to the show.
Thank you, Dr. Krishna Deepak. Nice meeting you and nice being with you.
Thank you, sir. Namaste to you. Sir, this is a very interesting area for me. I also have a little bit of experience in this aspect because I worked as a ER physician. I dealt very closely with critical care specialists. So, what made you come into this field? Tell us a little bit more about yourself. Where are you from? Where did you do your masters? And how did you get into critical care?
Okay, it's a very interesting question, which I'm very happy to go through. Yeah, I am Dr. Basavaraj, where I have come from North Karnataka.
Okay.
So that is Ramadurga is a taluka place. Where I did studies in a taluka place, and at that time I studied in Kannada medium, almost up to 7th standard. And up to 10th I was there in Ramadurga, and after that I studied my PUC in Dharwad.
Okay.
And when I was in Ramadurga, I was a good table tennis player, and I represented Karnataka table tennis team also.
State.
For the state, Karnataka state.
Great.
And hence my father wanted me to become a better player. Hence I went to Dharwad. There I had joined a Cosmos Club, and I was studying in a school called as KE boards.
Okay.
At that time, all 10th matriculation, they used to get a lot of ranks. So my father felt that I can do my studies as well as table tennis. And then, yes, I got into medicine. I did my MBBS from JSS Medical College, Mysore. And after my MBBS, I wrote my PG entrance exams, and I got a very good rank. And during that time, I somehow I felt that I should start working in a critical care. So I started working in a ICU. Obviously, with post MBBS experience, I was not much experienced, but I got fascinated during that time. And during my MBBS level also, I felt that somewhere in the ICU we could do better. So after MBBS, my rank was announced, but still I was not joining the MD medicine, which I was interested. So that's when I started working in a critical care. Some of the hospitals I worked without any pay also, because I'm interested in critical care. And then I joined my MD medicine from Bangalore Medical College, Bangalore, which is one of the best college all over India. So in BMC also, I wanted to do my thesis in critical care, but I could not do my thesis. So I could do my acute stroke as my thesis.
Okay.
And that's when I felt that critical care is the one which keeps progressing, and we need to keep learning. And I can do as an emergency wise, like how you said, you are from the ER level. So my blood pressure, heart rate used to pump in whenever there were sick patients, rather than sitting in the OPD, which I love that also. So that is when I felt that I should be a critical care physician. So I met the top critical care intensivists at that time. I don't know whether you might have heard Dr. Vineet Nair.
Yes.
During my MD days itself, who was there at Manipal. And I had told my critical care interest to my guide, Dr. Puttappa Chandrasekhar. So he's one of the best medicine teacher. He also asked me, you go and meet him so he can guide you. So that is when I was interested in critical care. And yes, I could speak little Telugu also because after finishing my MD medicine, I worked in a place called Nizamabad.
Okay.
And there they said me I'm an intensivist, but actually I was a physician. So there were ventilators also, where I felt that no, physicians cannot be just an intensivist unless there can be a training. So that is when from Nizamabad I moved back to Bangalore Manipal Hospital.
Okay.
So Manipal Hospital is the one where I got trained under Dr. Jose Chacko, Dr. Somanath Chatterjee, and yes, with the senior consultants also. So that is when I got my training in critical care. I did my IDCCM at Manipal Hospital, Old Airport Road, and I did my European degree in critical care also. EDIC also. And over a period of next 4 years, 5 years, I started feeling that no, critical care is a closed unit only. So I was losing my physician touch.
Okay.
So that's when I also thought, no, I should do a physician practice also. So luckily, I could move to Manipal Malleshwaram, where I was allowed to work as a physician as well as intensivist. And then currently I'm working as a physician at Manipal Malleshwaram, and I'm working as a consultant intensivist and academic HOD as Bhagavan Mahavir Jain Hospital, where we also run a critical care post-MD course under ISCSIM, that IDCSIM course.
Okay.
So every year 4 students are there. And so I'm a physician here, fairly a good practice. That's why I could come late. I'm sorry. And I'm an intensivist also at Bhagavan Mahavir Jain, where we run our critical care course. And I was just mentioning you that, yes, we also run a critical care group called as Plexus Critical Care Group, wherein a smaller hospitals, since I worked in a corporate hospital, what all protocols can be done, I also felt that we can also give it to a smaller hospitals. That's how around 7-8 hospitals where we run a critical care group practice also. So this is what I think you mentioned brief. Maybe I was a little longer. Also.
No. Actually, our audience need to know your caliber, your background. So they will be able to connect better. They will be able to understand what kind of a person you are. And your many achievements actually... they are like Olympic medals. So, coming to this podcast, see, ICUs are of different varieties. We have medical ICU, neuro ICU, cardiac ICU, but today our focus is totally on the medical ICU aspects. What are the new recent changes that you have seen, equipment-wise or protocol-wise, that you have seen that you can share with our audience?
Yeah, maybe little... Before that, I would like to say, since you asked the various types of ICU, with respect to the medical ICU, I could say that it can be managed as a closed unit ICU, or it can be managed as a open ICU, or it can be managed as a semi-closed ICU. So closed unit ICU are the one where the patients are admitted under a consultant intensivist primarily, but other team members will come in and they go. All the decisions are taken care by the primary consultant physician. Only. It needs a good setup, good trained consultant. Entire team should be aware about that. The other kind of ICU is, it's an open ICU where the intensivists are there in the ICU, but patients are admitted under a primary consultant. And majority of the calls are taken by the primary consultants. And in between is the approach where we call it as a semi-closed ICU, where there is a consultant intensivist who runs the show, though the patients are admitted to the primary consultant, and 50% share goes to the consultant intensivist as well as the primary consultant.
Role responsibility wise.
Yes, it can be divided. So this is what are the 3 types of ICU which I can say. And coming to the question, what you asked, what is the progress that has happened?
What are the newer things which are happening in this space?
Yes, I would say that with respect to the doctors. So previously, the intensive care was not qualified, not defined. It is based on the experience, how it was there. Maybe I can say 15 or 20 or 25 years back.
Just to small interjection, majority of ICUs, especially in the maybe a decade or maybe a decade, you can say, are usually MD anesthesia managed.
Yes.
And DM critical care is very rare.
Yeah, it was hardly on 8 seats were there 10 years back when I wrote my exams.
So that is where I think EDIC and all these certifications have come in.
Yes.
So please.
Yeah, so I was telling that, only the experienced people were called as an intensivist, but there was no qualification was there. So with respect to the India, ISCSM has done a great job. 1-year course post-MD, IDCSM, they call it as Indian Diploma in Critical Care Medicine. Majority of the Indian ICUs are managed by these IDCSM.
What is the prerequisite qualification requirement to join this course?
This is, one should be a post-MD, either in medicine, pulmonology, anesthesia, or even the surgery also.
Okay.
And they should work in a ICU which is recognized by ICU for 1 year. And at the end of 1 year, they will have to go through the theory as well as the practical examination.
Okay.
So that is one qualification for intensivist, though it is not recognized by the MCI.
Yes.
The second one is, yes, of late, previously the DNB critical care, which was 2 years, it was called fellowship, but now it is called as a DNB critical care only, which is equivalent to the DM critical care.
Yes.
So these are the two qualification which has come in India, which makes a difference that yes, there is a qualified intensivist versus there is a non-qualified intensivist.
True.
So since you asked with respect to the profession, yes, we are recognizing the people who are qualified intensivist who have spent time only in the critical care, and they can be obviously little better than a person who is only who is not spent time in the critical care. Like you mentioned, the anesthetists are there in the OT, they are very good, but they may not be able to spend time in the critical care. So hence there has to be there has an exclusivity of professionals which are there who manages only critical care has come over a period of time.
True.
So that is one thing. With respect to the equipments and the availability, yes, that also has moved. I think significantly there are changes compared to the ventilators what we had, compared to the monitors what we had, compared to the newer things like ECMO and all which has come into the ICU. So there are the rapid change of management also has happened. So these are the two things which I can say that yes, it has happened over a period of time, and it has made difference in the care to the patients as well as the outcome also. Obviously, the cost also gets involved.
Definitely. You put up a very interesting topic, ECMO. So how is your experience? Have you seen any ECMOs? Have you done ECMOs? Or
yeah, to be frank, I do not call myself as ECMO trained intensivist. But as an intensivist, I know when I need to shift my patient for the ECMO. We have done ECMO, but I do not say our center is a ECMO trained center. But this is an evolving branches, and at the same time, it cannot be done for all the centers. It needs a training as well as the experience as well as the cost that can be involved also.
What my experience in pediatric ECMO is very successful, but adult ECMO is...
Yeah, the ECMO, like 10 years back, we used to say ECMO is like, it is like 100% mortality, even if you put. So there was no results. But over a period of time, it has been changed that no, 10%, 20%, we can see even even in Bangalore also, almost around 40 to 50% survival on patients who are on ECMO. So that is a good result actually.
Wonderful. Nice. So ICU, especially medical ICU, I think, correct me if I'm wrong, but my experience is majority of them are usually sepsis kind of cases, MODS and sepsis kind of cases. So do you agree with this characterization, or is there some other condition patients that actually fill up medical ICU more?
So what you said is correct. Sepsis is the predominant patients what we get. And since you mentioned neuro ICU, cardiac ICU, those are all the patients where without sepsis they get admitted, majority. But medical ICU, and which I can say that some patients like, we are in a multidisciplinary intensive care unit where I work. So obviously we get a neurology cases, which is a GB syndrome, myasthenia cases, which is a GB syndrome. So maybe a poisoning, which is not sepsis. So there are a few sets of patients which may not be sepsis,
yes,
but majority of them are either admitted primarily with sepsis or later on they will end up with the sepsis.
Understood. So especially in your scenario where you treat a neuro case, a non-infectious case, and a very severe infectious case, what kind of protocols or what kind of things you do to see that there is no cross-infection in your setup?
Yeah, that's a very important thing which has to be managed in the ICU.
Because where I worked, there was a strict no. When the MICU was full, the patient was very critical. If I'm trying to shift to SICU, there are beds in SICU, but they even for a few hours, they won't be ready to shift sepsis cases. So tell us, please.
Yeah, see, this is a common issues that happen. So you are asking that how do you manage the cross infection should not develop, and it is I feel it is very important. So unless this is being taken very seriously, and you will not be able to get better results.
You should have an isolation inside the ICU
Yeah,
itself.
so we have got an isolation beds itself. Or apart from that, what we call general infectious care that needs to be done, the hand hygiene, 1:1 nursing staff.
Yes.
The doctors follow the strict aseptic protocols. Infectious control team drives or sees or punishes wherever there is a variation is there. And the consultant intensivist also drives this infection control program. So all these things will help to reduce the cross infection. But of course, yes, cross infection do happen. And generally, like a patient who has come with non-infection, getting into the cross infection, getting worsened are very less than what we have seen.
Right. Good. You also keep the equipment separate. Everything has to be separate because there are all chances of cross infection can happen.
A bed has got its own monitor. It has got its own ventilator. Obviously, circuits keeps changing.
Yes.
1:1 nursing staff or maximum 1:2 nursing staff what has been given. And use of hand rub and hand wash, those things will help to prevent the cross infection in the ICU.
That's true. See, these infections, and I believe, or my experience tells me, is that majority of India is gram negative.
Yeah.
India is a gram negative condition. Most of the infections are gram negative. So, antimicrobial stewardship is a very important aspect. Because we are getting a lot of resistance cases now. So what has been your experience with antimicrobial stewardship? What, for example, how do you, in your center, how do you give a broad spectrum antibiotic for what condition, and for patient comes with, say, counts of 20,000 WBC, the focus is urosepsis. You're thinking it is urosepsis. What is the antibiotic of choice according to you as per your antimicrobial stewardship? Or does it change even for a similar clinical setup?
Yeah, so I think it's a relevant question. Maybe for that I need to go little, what I can say, more introductory things.
Please.
I mean, since we got teaching programs, we always teach our students, even though they are post-MD anesthesia or post-MD medicine. Whenever we come across, we ask them whether are you labeling as sepsis or are you labeling as a non-sepsis. That means or there is no sepsis. Obviously, we ask them to go through the SIRS response, pulse, temperature, respiratory rate, and all. And we also keep asking them, is this fever? Is this tachycardia? Do you think or can you explain because of the non-infectious cause?
Okay.
Like, for example, pancreatitis, it may be non-infectious.
Yes.
So hence, the definition of that sepsis has to be given very careful. Definition not just includes the SIRS four criteria. One needs to spend more time on the symptoms, signs, clinical examination,
history,
and then go through the investigation and microbiology and all, rather than going from the reverse way, saying that somebody has got a counts of 14,000. No, I will label it as a sepsis. No, it could just be a SIRS response without infection. It could just be a burns. It could just be a pancreatitis. And similarly tachycardia. So those are the things which always we say that yes, these SIRS response could be non-infectious as well as the infectious. Then once we label patient having a sepsis or maybe a septic shock, we also ask them, obviously after managing your airway breathing circulation, we also ask or we also want them to identify where is the source. So source, generally we say either it could be from the lung or community acquired, hospital acquired, or it could be the urine which you are trying to mention, whether it is complicated, non-complicated. Is it the skin and soft tissue infection, or is it the brain infection? And then we identify the organ, and obviously we start thinking what could be the most common organism. As you mentioned, most common organism among all these things is gram-negative bugs only. But when we come to the cellulitis, osteomyelitis, predominantly a gram-positive organisms also can be there. That is when we also ask, we also teach, or we also follow, saying that yes, which antibiotics you need to use for a which particular organ involvement and what organisms you are expecting in your ICU. It may be a community acquired, and obviously it may be a hospital acquired infection. So since you asked about antibiogram, so that is when I was trying to tell you about we need to identify appropriately sepsis, septic shock, which organs are involved, and based on the organ, which organisms I am expecting. So the diagnosis is more important at this point of time, because we are trying to treat empirically based on these judgments. And once we label a diagnosis, saying like, for example, it is a simple urosepsis versus complicated urosepsis. So based on that, we have defined, yes, if you think of so and so, you need to use so and so antibiotics in our ICU or in our hospital when it comes to the ICU. Obviously, patients are sicker, immunocompromised, hemodynamically unstable. We tend to go towards the higher antibiotics. That's what we have written. This is empirically, but when it comes to the microbiological proven cases, so obviously based on the culture, we need to decide what antibiotics.
You see the MIC values and choose.
Yes. So based on that, we'll decide, depending on again which organ we want to cover, what are the adverse effects, and obviously the cost that gets involved. I know the cost of one of the MDR bugs antibiotics will range per day around 10,000 to 20,000 for 5 days, 7 days, you can imagine. So we need to think about the cost also. And coming to the MDR bugs, and that's when it comes about the antibiotic stewardship program. So there we need to start thinking that yes, which antibiotic we need to use for which particular disease. And over a period of time in our ICU, whether are we getting more and more multi-drug resistant or carbapenem resistant bugs or the cephalosporin resistant bugs. Hence, there is also a protocol for the 3 to 6 months all across the hospital, whether we can stop one particular antibiotic also.
Okay.
And there is an infectious control team also are there round the clock, which I'm a infectious control team member as well as a chairperson. And we also say that beyond this, consultant cannot prescribe, or even if he prescribes, he need to give us 1 to 3 justification why need to be started. And the infectious control officer or initially it goes to the nursing infectious control nursing team, and then we 4 or 5 members also discuss whether it is appropriate or not. They can start, but again whether we need to continue will be taken care in the next day. And and we do not use a particular group of drugs for 3 months to 6 months, so that the cross resistance also can come down.
Understood.
So this is what I can say broadly. I do not know anything else you wanted.
No. You're very apt. How frequently do you fumigate ICUs? What is the protocol?
See, by and large, the evidence says that there is no need of fumigation as such, unless what I can say, there is a TB which is there. Otherwise, by and large, the evidence says that there is no need of fumigation. A thorough cleaning, infectious control program
Surfaces
for that, surface cleaning and deep cleaning should be good enough. But in our ICU, also because you are not able to give the space for fumigation, because most of the ICU it is occupied. So if I say no, I want to block 12 or 13 beds, and where to move is also difficult. So evidence wise, there is no need of fumigation as such, but maybe what I can say, once in 3 months, once in 4 months, depending on the case which is being admitted, then we do think of doing a fumigation also.
All right. So that is very interesting to know. So coming to ICU care, what is the biggest challenge in convincing the patient for intubation? Because the word is, as soon as you tell them about ventilator and intubation, they immediately say that, no, this is not going to happen. The same thing happens with dialysis also. When you want to do renal replacement therapy, I think you might have faced many challenges. So how do you convince them, and what can you share with us a very complex case, or even a case that baffled you, a patient that baffled you? You thought it was something, but it turned out to be entirely a different thing. Any kind of such experience that you faced?
So I think the first thing you were asking about...
how do you convince patients? How do you counsel them for intubation or dialysis?
Yeah, this is an interesting thing. For example, as a qualified intensivist gets training, and it is a good thing that family counseling also is a part of their passing out the examination. So there is one table itself where all these things were asked to all the trainees. And I think I told you about the doctors who have grown and the equipments which has grown. And similarly, the patient families, then their expectation also has
Yes,
grown.
definitely.
And many of them depends on different strata. Many of them are aware these things are there, these things can be tried. They keep asking what else can be tried. So that is a one group of patients where they are fairly okay what needs to be done. Obviously, we need to explain, they agree. But there are other set of group of families which I think that's what you are asking.
Yes.
ಕನ್ನಡದಲ್ಲಿ ಸರ್ ಟ್ಯೂಬ್ ಹಾಕಿದ್ರೆ ಅವರು ವಾಪಸ್ ಬರಲ್ಲ ಅಂಡ್ ಟ್ಯೂಬ್ ಎಡ್ತೆ ಅವಳು
They will not come back.
they will not come back. So that's what is the thing what they come with.
Yes.
But when we take, or when I take them and show them,
the reason why I say is because the patients nowadays, they have become very aggressive in some aspects, especially in ICU, where your close one is almost on the deathbed, fighting for the life. And there are a lot of contrary views that many of the family members are saying, why they started dialysis? Oh my God, now the condition has deteriorated. Oh, they intubated ventilator. Oh my God, he's not going to come back. He or she is not going. So how do you counsel them? What do you talk to them?
Yeah, so generally it needs a clinical acumen, clinical, what I can say, the diagnosis. And when it comes to the bedside management of the patient, you plan this is what is required 1, 2, 3, 4, and then you will come to the patient family. So whatever you want to do, obviously you need to be in touch with the family and family to be with you. So that's why I take the patient family inside, show them that this is how your patient, these are the fair parameters at this point of time, and see the oxygen, see the respiration, see how much is struggling, and show the numbers and all, and then come outside the patient, sit in a counseling room. Once they see the patient, they also know that he's not good. Though they do not know, they understand it is not good. So that is what is the first thing which helps me, that yes, family knows what is happening with the patient. Family at least understand something major is wrong. So that is what I suggest the intensivist or the primary care physicians to show the patient, spend some time with the patient.
Empathy is required.
Yes, explain some 2-3 parameters. Do not start talking in front of the patient, and then come beside and tell what you are thinking, what are the parameters, and then always give an option that medically we feel that intubation is what is required. The chances are better. And also tell them that intubation is not the treatment. Intubation is only the supportive care for the tube and ventilator. In majority of the cases, it could be a treatment also, and till the underlying problem improves. So it may be 3 days, 5 days, 1 week, 10 days. And they may also ask, illa sir, I mean, I will speak.
Please.
Illa sir, tube ilde manage ಮಾಡಿ.
Without tube manage.
Without tube you manage. And if they do not give the consent, majority of them, after seeing the family, telling them, and we giving them the hopes versus not doing, majority of them will agree. But some patients do say that no, you wait for some more time. So obviously we cannot do without the family's consent also. Maybe after 1 hour, 2 hours, if there is little deterioration, again you can call the family and tell them this is what is required. We need to secure the airway, and depending on the underlying disease, the prognosis matters. So hence there are patients who got out of ventilator within 1 day, within 10 days, within 15 days. And the best part, what I feel is, I always feel that what patient party are asking is correct and truth based on their experience, based on their knowledge.
Okay.
So here I am the one who need to say that what is their knowledge and what is required. And 99% of the family do agree, and they have agreed. And 1 or 2% family we had difficulty. Obviously I need to take who has seen the primary consult, who are their family members, do I need to speak to their doctors? And most of the times they agree. And in case if they do not agree, they have the rights to say that we do not want tube and ventilator for my patient, for various cases where the patient's treatment we feel that gets better. If they do not agree, there are different causes where patient is elderly, he cannot come out, and we also feel it is not required. We give them the option, it should not be required. So I feel it needs a lot of time, your ability to see the scenario, and your ability to give a full respect to the patient and disease, and similar and more respect to the patient families knowledge, understanding what do they want. And I can say that majority of the times we
Respect their
succeed.
wishes.
Yeah, we succeed. The reason for not intubation is lack of knowledge. They do not understand the disease, and majority of the times their previous experience and the finance also.
Yeah.
So hence, if we understand these are the things, then we can always talk to them.
You touched upon a very interesting aspect, which I want to dwell, maybe a little controversial. Euthanasia, DNR. So India, euthanasia is not legal.
Yes.
DNR is something that I have written. I have written multiple DNR notes. I have taken patient attendance signatures on that. High risk concerns, DNRs. What is the legal validity of DNR? Because as far as I know, DNR also has a very shaky legal standing.
Yeah. Okay. So I think this is a very interesting as well as difficult topic where I can say 2 + 2 is 4 only. The way I have been trained under my teachers, like Dr. Jose Chaco and all, when I was a trainee itself, we have been taught and we have seen saying that you do what is best you feel for a patient to be done. Do not do which you feel it is not going to help.
Don't do no harm.
Yeah. So do
First
no,
tenets of medicine.
Yes. So that is a thing. And that is what clinically we practice rather than worrying for what law says, what the family says. So that is a first basic principle, what I felt that yes, we should do what is good for the patient, and do not do which you feel it is not going to help. And as I said, second one is yes, respect the family's wishes also. Whenever such cases of supportive care, DNR comes also. And coming to the legal aspect in Indian scenario of the ICU, there is very good progress has happened in terms of the intensivist, in terms of the patients also. Because even the comfort care, non-escalation, and a withdrawal of the support, these were not approved by the court of law in India. But now it is been approved that yes, you can think of comfort care, non-escalation, including the withdrawal of the life support also.
Okay.
The legality of that, what they have given the Indian court maybe a year back or 1.5 years back, which is been approved by the court, is yes, whenever you think of, if you think that patient is not going to improve, it is a futile course, then you discuss with the patient family members. That is what we call a primary group or a primary group. And what the law says that yes, you also form a secondary group. One doctor may be outside the hospital.
Okay.
And involving the primary group. The secondary group of team also see the patient. They will also speak to the family. And if both of them come to a consensus that yes, withdrawal of the life is the best way for this so-and-so person. What it says is, after the first group, second group, you send an intimation to the jurisdiction or the district magistrate saying that both the team have felt like this and we are going to do a withdrawal of the life support.
All right.
You need not have to wait for the court to give us an order, but you just intimate, and legally it is been approved that yes, you can do a withdrawal of the life support.
All right.
But majority of the times, obviously, we get into only the first group where the primary care and the other doctors who are involved into that doctors sit to the family. And if the medical team feels that it is not going to help, cost is different. We will not bring the cost into this because many withdrawal happens because of the cost issue also.
Yeah, true.
Yeah. So which that is a totally different matter. So wherever we feel that the care is not going to help to this particular patient,
Or which
from
will
all
not
the
lead to
primary
quality
team.
of life, or
Yeah, and the primary physician, I mean primary patient caregivers also agree for that. And yes, we can still think of doing a withdrawal of the life care without worrying for the code. And again, whenever this question is asked, I always been thought this: what is good for you? You feel your team members, if you also are in the same line, you can always do is what I feel.
so this
And-
gives again opens up to a new, not a new, but a new line of thought: organ donations, because ICUs are the forefront of counseling prospective organ donors to donate their organs. How do you go about it?
Yeah, so obviously it comes whenever we think that a particular younger patient who was near dear, who was totally all right, and suddenly goes down, and then we say that he's, I mean, in a common language, brain dead, or the brainstem reflexes are absent. And that is when we also go through the what we call the brainstem reflex being absent,
Apnea test.
apnea test, and all those tests we'll do. 2 sets of a test also is done, and then we confirm that this is how his condition is there. And the family has to accept. That is the first point where family needs to understand that he's on ventilator, his heart is beating, but brainstem reflexes are absent. So the first part is about that particular patient and that particular family, and we need to convince and take enough time.
Without any doubt, you need to establish brain death.
Yes. And once we establish there is a brain death has happened by the set of protocols, and the family also understands, that is when, if we feel that yes, this patient's organs can be used for others, that is when we need to start the initiation to the patient party, saying that there is an option like this, which is a great thing that a patient or the family can do. And we cannot put any force in that, neither we can deny also any in that. We can spend enough time with them. And I can say around 50 or 60% of the times we get a negative answer, and which we have to agree and respect. But 40 to 60% of the times whenever we are discussed, and they also do think. And it is not simple aspect when we talk about organ donation and family being agreeing. The question also comes, are the families emotionally prepared? Who will take the cost till then? Yeah, so what will happen to the patient? Whether do they give the body to them? So those are all the non-medical aspects also come into the picture. But yes, whenever the patient family are little agreeable, so we have got a team, what we call organ donation team. The organ donation state coordinator also pitches in. Obviously, all these things are done without any cost or finance that gets involved. The only thing in our mind is, yes, whether it can be used for somebody else. At the same time, we should not put the pressure to the family. So these things will have to balance. And and then once they agree, then the next step goes ahead, obviously, which will help to save many patients
people.
also.
Yes, true. Nice. ICU patients are bedridden, majority of them. And one condition which happens in these people is deep vein thrombosis.
Okay.
So what is your protocol for prevention, DVT prophylaxis? What other cares like mechanical devices do you use regularly, or DVT prophylaxis, or depending upon the clinical condition that you take?
Yeah, it is interesting. One is about DVT prevention or prophylactic, what you're asking. Obviously, once the DVT comes, what we do is totally different. But obviously, most of the patients who are there in the ICU have got high risk of having a DVT. Either they've got a COPD, or or they are bedridden, they're not moving their legs and all. And we got a protocol which we go through the ICU, like what we call it as a fast tag BD in each shift by our doctors as well as the nursing staff. So in that, obviously, T is the thromboprophylaxis, what you are trying to manage. In that, we divide mainly into the two types. One is the chemical, that is the drugs what we need to use, and the second one is the mechanical device. So mechanical device always comes when the chemical or the pharmaceutical things are contraindicated or still not decided. So that's when it comes. So every 8 hours we do check in our patients whether does he need a pharmacological DBT prophylaxis or whether he requires a mechanical. As soon as the first question says pharmacological prophylaxis not indicated for so and so reason, he has a bleed, he's ongoing bleed, so then immediately he will be put on a mechanical DBT prophylaxis. But wherever there is no contraindications, he will be on a prophylactic dose of anticoagulant. And many of the studies and the evidence says that yes, the pharmacological prophylaxis does help to prevent the DBT, because we also seen wherever the pharmacological prophylaxis are not given in majority of the bedridden, debilitated neurorehabilitation patients, we have seen landing up with 15th day or 16th day with DBT and coming down to the ICU with the pulmonary embolism. And so we need to also balance the risk of prevention versus whether the risk of bleed whenever we use even the prophylactic dose also, because majority of the ICU patients also we got deranged coagulation, low platelet, some amount of bleeding also. But this assessment goes every 8th hourly in our ICU by the doctors as well as by the nursing staff also.
So what is your choice? Do you use low molecular weight heparins or what do you use for DBT prophylaxis?
Yeah, when it comes to the pharmacological DBT prophylaxis, depending on the patient's condition, so we do choose the various forms of the anticoagulants. The broadly is one is the heparin, and the other one is the low molecular weight heparin, and obviously the oral anticoagulants also at a later point. The heparin we do use because it is a short acting, and if we know that yes, after 4 hours, 6 hours, I need to take this patient for a surgery, or it has got antidote also, so that is when we can use the heparin and all. But in our eyes, but obviously it needs some monitoring. You need to monitor the APTT, and based on that you adjust or do not adjust, because it's a prophylactic dose. But when it comes to we are more comfortable on using the low molecular weight heparin. Usually the standard dose is, standard advice is you give the low molecular weight heparin in the night as a DBT prophylaxis in the night. Suppose 8 p.m. or 10 p.m. so that the duration till next 12 hours. By the time next day morning, you can decide whether the patient needs to go to the OT or patient needs a surgery, patient needs a fasciotomy. All those things can be decided. So our general common protocol advice is you give the DBT prophylaxis of low molecular weight heparin in the night. Since you asked which low molecular weight heparin, yes, it can be a Clexane or it can be a fondaparinux wherever we suspect possibility of low platelets or the hit is been involved, or it can be a dalteparin where the kidneys are involved. So these are the various things goes in our mind whenever we want to use either the heparin or the low molecular weight heparin in our ICU.
Mechanical devices, in the setup that I worked, we used to put stockings on everybody who comes to ICU. But compressive stockings and other things, we used to decide later. So TET stockings and compressive stockings are like compulsory norm for any kind of ICU patients. One thing that for me, the most important test, as soon as the patient comes, and I am suspecting sepsis based on the history, is an ABG. When I was working at the corporate hospital, ABG was my savior. So do you feel, what are the basic things that an ICU should have? A functioning ICU at a district level, because cost, equipment, all these things, they have issues because they can't procure or they can't maintain. What should a basic ICU should have at a district or a village kind of setup?
Okay, I'll come to the last one. I will come to the first one. I think we were at the stage where mechanical DVT prophylaxis, either a stocking or the compressive stockings. So I feel that the compressive stockings are of no use to prevent the DVT prophylaxis. It may help to compress the vein, and the mechanical DVT pump only, which compresses every once in a minute only, is advisable.
Wonderful.
We not only put for the calf, it will be put for the thighs also.
Yes.
So that is what is required, and those are obviously much better than simple socks, which we do not advise as a DVT prophylaxis stockings. Though many of the people do use and do believe it can prevent the varicose vein, but it may not prevent the DVT. So that aspect which I wanted to make it clear.
Okay.
And we run with a yes when as soon as we said mechanical DVT prophylaxis means it's obviously it is a compression stockings both to the calf as well as the thighs. And even if one patient has got some problem, some surgery, some fasciotomy is done, we put it for the one limb also. And coming to the another interesting topic which you asked, what all equipments one need to have. And see, I would say, to be frank, I have worked in a setup where ICU is, we have grown in a setup where minimal things were there. And what I would say is, critical care can be given in any of the places, including the primary health care, including the district hospital, including the corporate hospitals. But what one need to understand is, what else can be given which is going to help, rather than I continue to take care of this patient with my available resources. So that needs to be clear. And
so just stabilizing and then shifting to a higher center.
Yes, versus there is a patient who has come with even the hypokalemic periodic paralysis. Yes, we can still manage with the potassium correction. Low sugar, we can still manage with the correction. Maybe in a setup with snake bite, they want to manage. So it all depends on how much they can manage, and they should also be aware what else can be managed in other ICUs. That is the more important thing. Suppose if I cannot do the ECMO, and our center do not have an ECMO, but patient needs an ECMO, but I need to.
You should be able to recognize,
and I should be aware that this can be managed in next center. So similarly, they also have to think that yes, if I cannot manage, what else can we? So that knowledge should be there. It comes only with the training, that what level next can be done, and obviously working in a setup where you are. So if you know the limitations, then you can always think that what else can be done. We call it as maybe different level of ICUs depending on what all facilities are available, like primary care, secondary care, tertiary care, and quaternary care ICUs. So based on that, we can think. Coming to the ABG, yes, ABG is the most basic thing what is required. But even if the ABG is not there, the clinical symptom signs, just a pulse oximeter, what the saturation shows, a clinical examination, what the carbon dioxide can be there, is a simple things what one can also look and then get into the ABG also. But it all depends on a clinical case scenario where setup is there, in which scenario you are trying to manage the case also matters.
What I feel is, correct me if I'm wrong, but a small ICU should have an ABG, X-ray, an ultrasound, and an ultrasound machine which can even do a 2D echo. These are some things. A ventilator is a compulsory thing. So I think this is the bare minimum basics.
Yes.
The doctor should be able to do a fast scan, a basic 2D echo, should be able to read the ABG well, and know the basics of all ventilatory settings. I think this, if we can impart in all MBBS students, because there we were not taught about all these things. Even during our postings in emergency, these are all the things I learned when I was doing my MD. So I think, correct me again if I'm wrong, that we should impart this education straight away.
I totally agree. Like, yes, there is an ABG, there is a echo machine the hospital has given, but there has to be a trained person who can do the fast scan, who can do the echo, who can do the bare minimum thing, critical care, what is required. So that's what it needs, a training. And to be frank, since you raised that the MBBS doctor should be trained, I totally agree with you. MBBS doctor might have spent a week into the ICU in his entire 5.5 years, depending on where they are. Maybe the DNB critical DNB programs, wherever in a corporate hospitals, they do spend, for example, in a like when I was in one of the best medical college called Bangalore Medical College, we were having a postings of 15 days in the ICU. So that is not sufficient. Even in our MD days, forget about MBBS days. During our MBBS days, yes, hardly we had entered into the ICU also, or you have gone there only because of your PGS post. And over a period of time, MBBS alone is not enough, and hence during the MBBS, nobody thinks that yes, I need to spend time in the ICU. Obviously, your next goal is that to get write the entrance and get into the post graduation. So that is how it goes. But yes, I totally agree with you. The ICU and the emergency care, since you are emergency physician also, including the BLS, ACLS, primary critical care exposure to these things is a must at the MBBS level itself, which can give them some interest whether what they want to become later. And irrespective of the specialty, what they grow into, maybe a pulmonologist, maybe a cardiologist, maybe a surgeon, maybe an orthopedic surgeon, these emergency skills, these critical care skills only can make them a better doctor in that particular specialty. For example, MD medicine person who is seeing the patient, who is examining the patient, and if he can decide, no, this patient needs airway, so he can call the next person even if he's not there. So those are the things which matters irrespective of whichever specialty they go. And I totally agree with you. This has to be taught at the MBBS level, and to be taught even at the MD level also, which again is missing. So those things we need to address.
These are
also
basic skills that
yes,
basics of critical care that needs to be taught.
Yeah. And since in our critical care education, it is a must that before he applies for the exams, he should be ACLS certified. He should have undergone the airway workshop, and only then he can apply. Forget about passing. So that is the good thing, at least what they have done here. So similarly, a basic clinical skill also has to be done at the MBBS level and the MD level in all the specialty, which I feel.
Okay. We're coming to the end of this wonderful talk that I had with you. So I'll harken back to the same question. I'll repeat the question again. Tell us something interesting, some case that baffled you, and you thought it was something and it turned out to be something. It changed your entire view. Something interesting for our audience.
I do not know whether this particular case needs to be discussed or not. All of our colleagues who were working in our hospital, they're all aware. There was one, I can say around 64-year-old. I will give you two scenarios. This is where it is against the doctor's odds and all. 64-year-old male, a chronic alcoholic, who had come with sepsis, septic shock. He was on 3 inotropics.
Okay.
He had a kidney failure. He had a deranged coagulation. He had altered LFT. He was in encephalopathy. 3 inotropes, not making urine. AKI with creatinine of around 4.5 or 6. Totally anuric, acidotic, on ventilator, on 80 or 90% oxygen support. Obviously, family also had got a financial issues. Family said, we do not want to continue, because we also told them he's not going to survive, he's not going to pull through. No, we do not want to continue the care, and we want to take him home also.
Okay.
So that is when at that time it was told that yes, the family do not want, patient is not improving. So the option were told to them about the withdrawal and then keeping him for a day in the ICU, then shifting him to the ward. And prepare the family that he's not going to pull through. Family were ready, saying that he's going to go down. So the life supports were withdrawal as per the medical discussion, family discussion, and treating team discussion and all. And the treating team also felt that he may go down in few minutes or few hours and all. But but this is against the odd, saying that after the ventilation he was able to breathe. Slowly he improved his oxygenation. Slowly he started making urine. And we have to say that let's see, because this is happening after 24 hours, we'll also have to think of moving him to the ward.
Okay.
And the question also was thought that in the ward care also he may not pull through, and he was not willing to taken by any other primary care consultants also in the ward. So obviously patient was moved under intensive care under him only into the ward. And over next 3 days, 4 days, 5 days period, this man started improving his kidneys, improving his breathing, and maybe at the end of 10 days he walked well. That means the treatment was continued, but the life supports were withdrawn for him. So that is when we felt that yes, whatever we decide as a medical person, there is something else, some other force
Working
also is
behind.
there. And hence I mentioned to you at the beginning that we need to respect what the patient wants and what the family wants, because I also believe that some of the family members have got gut feeling that what can happen to my patient family, what they have wished and all. Hence those things has to be respected. That is one aspect which gave us thinking that yes, it is not, everything is not in our capacity, some other force also is there, though we wanted to correct ourselves. So from then onwards we started telling that this patient may go down within minutes or hours. Then we also started telling the word which even I use it now. Yes, even after withdrawal, or even if whatever is taken decision, he may continue to breathe for minutes, hours, days, weeks, and if the miracle happens, he can survive also. So this is the sentence where we leave at this point of time after
Your
that
disclaimer
experience.
has changed.
Yes. So that is the one point. The other aspect is yes, sicker and sickest patients also, a young patient who are primarily obese, around 150 kg, who was intubated, ventilated for the hypoxia. He was on 3 inotropes.
Okay.
And the echo showed RARV dilatation, which is a new onset. So diagnosis of pulmonary embolism was done, and on 3 inotropes. So we thrombolized the patient. Did not show much improvement also. Then the cardiologist was involved. Then we took him to the cath lab. So the embolus and all were, the mechanical thrombectomy was done. And next 2 days, 3 days, patient did improve, where we thought he may not improve, he may not survive also. So that is the other aspect which I can tell. And there are many such examples which I can say. For example, right now we got one young, around 50-year-old, was admitted to hospital with a fever, cough for 4 days duration. And 5th day when he was supposed to get discharged, he became unconscious. He stopped breathing. He was intubated, ventilated, and the MRI showed there is a complete pontine infarct. So total entire pontine infarct is there. So he's quadriplegic. He's not taking breath. He's there with us since last 2 months, and the entire literature evidence says that a pontine infarct, such a severe one, there is a disconnect between the brain and the lower limbs.
Yes.
And hence he may not improve. The family keeps saying that yes, we want everything to be done. So he's up and down from the ICU 2-3 times, and sometimes he has only the because the pontine, in fact, he has only the vertical gauge eye movement. Hello, how are you? He just moves his eyeballs down. He moves eyeballs down, and that itself makes the family so happy. The wife, the children, their father, their in-laws and all. No, he's moving his eyes, doctor. So though we keep saying that he may not get better, but all odds of odds, we're still treating him, saying that whether he can get better. What we had also thought that he may not have any motor power movements, but at the end of 6 weeks or 8 weeks, he started obeying commands, that he's moving his wrist. The neuro rehab team is very good. So the neuro rehab person says that no, in the wrist he has got 3 movements, flexion response. So still we are fighting with all odds every day. He will end up with one or the other problem. But family hopes, says with all non-medical aspect, the prayers, the other things, including that I will take a photo and I will do a Reiki to the patient family. Can you allow? I said, yes, we'll allow. So you please continue all those prayers, but we'll continue to do our job. So they were also surprised whether doctor, they are allowing us to do this thing because they are requested. So those are the various challenges that what we go through every day in and day out. And we are here to take care of the patient, their families, and also improvise ourselves also.
Yes.
So that's what I can say.
Wonderful. Sir, it was a great learning experience today. You shared a lot of great clinical insights. I thank you and I wish you well. And I hope that you save more patients and bring great happiness and joy to your patients' lives, sir. Thank you very
Dr.
much, sir.
Krishna. Thank you very much.